When you have benign conditions, we're actually treating 3 gray, so a significant difference. And typically when you treat at a high dose, the goal is to destroy tissue like cancer tissue or cancer cells. But when we give a low dose, the goal is actually to modulate inflammation. And what it does is it slows down those inflammatory cells or those cells that release the chemicals that cause pain and inflammation.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Amanda Meyer, Family Nurse Practitioner in the Department of Radiation Oncology at the Mayo Clinic in Rochester, Minnesota, about radiation therapy for non-cancer indications. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome and thanks so much for joining us today, Amanda.
Thanks for having me. I am so excited to talk about my favorite topic.
Wonderful. Well, let's get started. Let's start off with a brief history of how radiation therapy has been used to treat non-cancer indications.
You know, radiation therapy, we always typically think of it as cancer treatment, but we can use radiation for non-cancerous conditions as well. And radiation was actually used for benign diseases actually right after the discovery of X-rays. By the 1920s, it was used a lot for different types of musculoskeletal, derm issues, and different types of inflammatory conditions. And over time, since the 1920s, we've actually really gotten a really good understanding of it. What are some conditions that it work best with it, and what are some risk factors with radiation for benign diseases? It actually fell out of favor in North America in the mid to late 20th century for a variety of reasons after World War II. A lot of them being that it fell out of favor due to just the lack of resources, the lack of radiation machines, the increase of pharmaceutical companies. However, a lot of the European countries really kept with treating benign conditions and started developing protocols and guidelines. And now, back in the US, there's this renewed interest in treating patients with benign conditions with low dose radiation.
Well, let's talk a little bit about those benign conditions. Which are most commonly treated with radiation?
So I would say by and large, the most common condition that I personally treat would be osteoarthritis. So arthritis of the hands, arthritis of the elbows, knees, feet, ankles. We can also do shoulders and hips, although we are a little bit more selective with those. But other benign conditions would be like plantar fasciitis, Dupuytren's disease, Lederhost disease. We can treat things like keloids, heterotopic ossification, epicondylitis. There's so many other things, and we're continuing to expand this benign practice.
Could you talk a little bit more about what types of radiation techniques are used in treating some of those non-cancerous conditions that you just mentioned?
Typically, we think about 2 of the most common types of techniques. The first technique is a superficial target, such as the orthovoltage or the kilovoltage X-ray, and we use those for your hands and your ankles or your feet. And then we have actually your linear accelerator. So this is using photons, sometimes electrons, but typically photons. And the linear accelerators, that's what every single X-ray or radiation center has. That's your standard radiation. And we like to use those more for your knees or your hips or your shoulders. And that's because it has a deeper penetration. It allows us to be able to have better targets. But even if you don't have an orthovoltage, we can still treat the hands and the ankles and the feet on linear accelerators as well. So there's a variety of different types of radiation techniques that we can use, and it's really based on what type of availability that your radiation center has.
Could you explain a little bit of the mechanism of action and how using these techniques for these non-cancerous conditions, is the mechanism of action for using them the same as what we're familiar with for cancer use?
typically, when we think about the difference between treating radiation with for cancer versus treating radiation for benign conditions. And the big difference is that there's a significant dosage difference. So for example, if you have a brain cancer, I'm treating at dosages of 60 gray, which is kind of the dosage terminology that we use in the radiation world. But when you have benign conditions, we're actually treating 3 gray. So a significant difference. And typically, when you treat at a high dose, the goal is to destroy tissue like cancer tissue or cancer cells. But when we give a low dose, the goal is actually to modulate inflammation. And what it does is it slows down those inflammatory cells or those cells that release the chemicals that cause pain and inflammation. We also use it to kind of slow down abnormal fibroblast proliferation, which means in conditions like Dupuytren's, which are more of a proliferation, we want to reduce that proliferation of those cells. And as a result, when we do that, it actually reduces pain, it improves function, and it actually, hopefully, a lot of times can improve quality of life in our patients.
That really is fascinating. I really have never thought about the use of radiation for anything other than oncology. So thank you. Thank you for sharing all that information. Now, you mentioned a little bit about the difference in dosage. What is the typical dosage and treatment schedule when we give radiation for some of these benign or non-cancerous conditions? And how does that differ from our treatment that we see in cancer settings?
This differs vastly in the fact that when we treat with cancer, a lot of times we're treating over 4 to 6 weeks. We're treating every single day, and patients are coming in Monday through Friday for these treatments. However, when we're treating for benign conditions, because it's an inflammatory condition, we're actually giving like very low doses every other day for 2 weeks. And the rationale behind that is you can't give all 3 gray at once or that low dose treatment at once. You have to give it every other day to allow those cells to kind of recuperate in between treatments. And so it's not a daily treatment, it's every other day for osteoarthritis and plantar fasciitis. However, if we're treating like a hyperproliferative condition like Dupuytren's or Lederhosen, we use a little bit higher doses just because it's proliferation. And so typically for them, we actually give daily treatments over 5 days, and then a couple months later, we give another 5 days of treatments. And so it's just different dosage ranges, but it's for a significantly less amount of time.
That's very important. I mean, I think that makes a huge difference, especially for the patients and their quality of life in terms of how often they're coming. And that also impacts how often we see them as nurses and how we can help to monitor their progress or any side effects they might be experiencing. So thanks for highlighting the differences of those two approaches. So when we are working with our patients and they're being evaluated for this type of treatment, are there any characteristics that might make somebody an especially good candidate for radiation for these non-cancer conditions, or are there any contraindications that would maybe limit their ability to receive this therapy?
The one thing that we think about typically when we're looking at what are good candidate characteristics, we do typically like older patients, so patients over the age of 65. And the rationale behind that is we know that there is a potential for a secondary risk of a skin cancer about 20 to 30 years after getting low dose radiation, like a basal cell or squamous cell skin cancer. And so the older the patient is, the less likely they are to have any adverse effects from that. We like patients to be older. We also really like to treat arthritis in sites that are distal from the trunk, so distal away from the bone marrow. So your hands and your feet, your knees, those are typically what we consider less risk sites. And so the one of the reasons why we do shoulders and hips on the linear accelerator is that we do have the ability then to be more precise with our treatments. So that does lower the risk of any types of toxicities in the future. But it's really important that a good candidate is someone who has been diagnosed with this. They've tried other measures. So they've tried physical therapy, they've tried medications, they've tried injections. It's impacting their quality of life. And so when we do the low dose radiation, they've tried other measures that haven't been successful. However, we don't want a patient who is so severe that they're ready for surgery as well when they're bone on bone because we know that radiation isn't as effective when they are that severe. So there's this sweet window where low dose radiation works the best in these patients. And so we really focus basically on how severe is their condition, how is it impacting their quality of life, do they understand the risks of low dose radiation, and what are their goals for treatment. For example, when we think about arthritis, this is a chronic degenerative condition, so we're not going to cure them, but we can significantly improve their quality of life. And so as long as they understand that the goal is improving pain, improving function, while understanding that this disease is still going to be present, is very important for a good candidate to have those expectations going into treatment.
And truthfully, that's not unlike important discussions we have to have with patients who are receiving it for cancer is understanding what is the intention of treatment and what do we expect to the benefit of this treatment to be. So it's interesting that there are still some of those parallels, even though we're talking about very different disease processes.
Absolutely correct.
So let's talk a little bit now about some of the side effects that patients might experience when they're receiving this lower dose of radiation for a non-cancer indication. Are these the similar side effects that we might be familiar with when it's used for a cancer indication?
Absolutely not. And I think that is the one misconception that we see with patients. They think radiation, and then they hear all these horrible skin side effects that they know people who've had radiation, or the severe fatigue that they've heard from other people who getting radiation. Because the dose is so significantly lower, so are the side effects. And to be honest with you, we really rarely see any side effects with low dose radiation for arthritis or plantar fasciitis. Typically, maybe they'll get maybe some skin redness or dryness. Sometimes they might get a temporary pain flare, but really it's essentially like they come in and they get an x-ray and they leave. There's really no side effects to this low dose radiation. When we're treating with a little bit higher dose for like a Dupuytren's or a Letterhost, because it's an anti-proliferative dose, those patients, they do get more skin redness, more dry skin. That's very temporary and that resolves within a week or two after treatment. But really, we don't see any acute side effects. The long term side effects of the radiation induced malignancy, again, is extremely low, 0.05% according to some of the European guidelines. Again, that could even be lower if you look at where's the location. Is it in a sun exposed area, or is it on the foot where it doesn't get a lot of sun exposure? We also think about patients who have a history of, a squamous cell or a melanoma, and we do consider that when we're treating. But because it is so low dose, we really typically don't see any side effects. And that's actually one of the biggest benefits of low dose radiation. So, for patients who've had injections that's painful, or they might be at risk of infection, or patients who have had other types of treatments, that are more invasive, this is a very non invasive, very benign treatment that is very successful. So, it's wonderful when we think about the side effect profile compared to cancer treatments.
And as you mentioned earlier, often patients are coming into radiation after they've tried other therapies that have likely had some side effects or have just not been successful. And so it sounds like this is great to be able to offer this and then provide hopefully another layer of relief from some of the pain and other symptoms they're experiencing from their disease. So, in the rare settings where patients might experience some side effects from the radiation, are there any interventions, pharmacologic or non pharmacologic, that you recommend that they can use to manage these side effects?
Absolutely. So I always encourage my patients to continue with the conservative measures that they're doing. So if they're doing physical therapy, or they're doing topical creams before bed, or taking Tylenol and ibuprofen, I encourage them to continue with that. I also encourage them that you have no restrictions while you're going through treatment. So continue with your activities of daily living to continue your momentum of physical activity. If they do get some skin redness or dryness, regular lotion works wonderful. So moisturization is often enough. If patients for like a Dupuytren's on the hands, they may need some ice packs or some cooling gels. Can be really helpful if it is warm or red. I've had patients who can get some cooling mitts that have been very successful and helpful with those. But I think just reinforcing that these get better within a week or two. They're not a chronic issue that patients have. And if they do get a pain flare, typically, anecdotally, I've been seeing that patients who get pain flares actually have the best outcomes. And so sometimes that reassurance is typically all that they need.
And then finally, as you sit down with your patients and provide them some education points, both before and after treatment, what are some of those important kind of pearls of education that we should be sure to be sharing with our patients? And are these different education points that we share with our patients that are receiving radiation for cancer?
The biggest education piece that I give the patients is that yes, you're still getting radiation, but it's a significantly decreased dose of radiation, and it is not the same as cancer radiation, nor is the intent or the dosage of radiation. And so, my goal of treating with low dose radiation is to improve your symptoms, to improve your function, to help with your quality of life. And it has been probably one of the most rewarding things I have done in my career is seeing these patients have such significant improvement in their quality of life. And so when I'm educating them about the radiation and the dosage, I say, the dosage of low dose radiation is equivalent to getting a chest CT or an abdominal CT scan. And once they recognize that radiation dosage to like a CT scan, a lot of times that's very reassuring to our patients when they think about the risk of radiation exposure.
Well, Amanda, thank you so much for joining us today on the podcast. I think this has really been an interesting conversation to understand. There's this whole sort of population of patients that lives just next door, maybe in terms of coming into our centers or coming to places where we are regular and used to seeing patients with cancer, but are receiving therapies that have lots of similarities and overlap with what we deal with in terms of sharing this information with our patients with cancer. So I think it's been very interesting to kind of understand both what's similar and also what's very different. And so I appreciate your time sharing that today. As we reach the end of the episode, we'd like to always run through just a series of some quick questions to help summarize some of the great points that we've covered. So to start that off, how can healthcare professionals maybe evaluate any hidden or implicit bias that we might hold just about radiation and how it's given for non-cancer conditions?
So I think one really important bias is that when we think about radiation, we don't need to immediately equate it with cancer or high doses of radiation or the significant side effects of radiation. And that radiation can be used as a adjunct to other types of benign conditions and can be really effective in healing as well. There's a lot of evidence-based information coming out of Europe who's been doing this for 20, 30 years and really taking that data and incorporating it in improving the care that we provide our patients here in the US.
What are some common misconceptions about radiation for non-cancer conditions?
A major misconception is that all radiation is the same, and it's not. Even when we think about low dose radiation of like osteoarthritis versus Dupuytren's contracture, the dosages are the same, the treatment is different as well. So, for example, osteoarthritis is every other day for 2 weeks, where Dupuytren's is daily for 5 days. So, it's not all the same. The doses aren't the same, and the toxicities aren't the same in benign diseases, even compared to cancer treatments. Another misconception is that radiation for benign disease is historical. It's only been done in the past, and that's really not true. We've continued this international treatment of low dose radiation, and we really have a lot of experience from other countries that we can utilize and build our own practices with.
What is something about this topic that's not often discussed, but you wish people knew more about?
I really wish people appreciated how interdisciplinary this is. So we need to get referrals from family medicine and from primary care and internal medicine and pain medicine doctors and inflammatory doctors and podiatry and pain specialists. And we really need to use this multidisciplinary approach to get earlier referrals for patients because there is this sweet window of time where low dose radiation works the best.
What additional training or education do you think oncology nurses or maybe any nurse needs to stay current on this topic?
I think that just understanding the biological rationale, the dose concepts for benign disease, really patient education on different types of condition specific diseases that we can treat, and really setting that expectation and education for our patients is really important when we are taking care of them and being able to provide that reassurance for them as they're going through these treatments.
And finally, are there any additional resources for patients or other healthcare professionals that you would recommend who might want to learn more?
So the DEGRO guidelines are extremely helpful. These are guidelines that are put forth from Germany that kind of set standards and treatments and algorithms to help us with treating for low dose radiation. And it really provides a lot of literature to guide us in treating these patients. There's also a lot of information on different types of studies and reviews and clinical trials as well to kind of really build your knowledge about low dose radiation.
Well, Amanda, thank you again for joining us on the podcast today and sharing all this information. I really appreciate your time. Do you have any final comments to share with our listeners today?
So, my final takeaway would be that while radiation for non cancerous conditions is not for every single type of patient, it's not for every benign diagnosis, but in those selected patients, this can provide a meaningful, low burden option that not only reduces pain, but it improves function and truly improves their overall quality of life. And it has been such a rewarding part of my career to be able to help these patients in a different way than just treating with radiation for our cancer patients.
Well, thank you again so much for joining us today.
You are welcome. Thank you so much for having me and let me talk about one of my favorite topics.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.